Dear Pure Urology viewers, good evening one and all. Today topic is related to the RIRS, that is a suction directly through the scope. As you all know, recently also we have done this topic with the access sheet. Here it is directly with the scope. No doubt already certain papers have come. Suction is going to play a role. Ultimately, all the stones in RIRS are made into dust, whatever method you use. So if that dust is more in high volume stones, because recently RIRS is used in high volume stone also, a lot of dust will be there. Whether that causes any reformation of the stones or nidus for the stones is a concern. So if you suck all those dust, then at the end of the surgery, you will be happy that you have not left anything behind like in PCNL. So we are competing closely with PCNL, even in large volume stones. In this matter, today's speaker, Dr. Mohammad Salim, is special because he is continuously doing work with thulium fiber laser for a long time and continuously evaluating different laser settings as well as the role of suction. Not only that, different role in soft tissue ablation. He continuously presents everywhere in the society as well as the media and discusses about these topics and also has written paper on this dish. I will officially introduce Mohammad Salim and then I will hand over the program to him. So today topic is RIRS thulium fiber laser direct intrascope suction. Speaker is Dr. Mohammad Salim. He did MBBS from Manipal University, Master of Surgery from Rajiv Gandhi University, DNB Urology under Rai Chali sir, who is very senior in Calicut, specialist endourologist practicing at Mangalore and Northern Kerala, vast experience in all kind of endourology procedures, senior consultant and HOD Urology, Department of Urology, Baby Memorial Hospital, HOD Urology Department, Kim Sunrise, Kerala, India, Senior Consultant Urologist, Apis Kidney Stone Institute, Mangalore, Visiting Consultant, India Hospital, Mangalore, Ex-Visiting Consultant in Metro, Calicut, Assistant Professor, Father Muller Medical College, Mangalore, India, Senior Resident at BMH, Calicut, 2008 to 2011. And now unique recognition is that, as I mentioned, he has a lot of experience, advanced and sophisticated laser. This is a TFL laser. He believes in it and he has shown the results. One of the leading TFL endourology surgeons in India, invented and pioneered most advanced world-class future gold standard bloodless procedures like Diss is known, and TfL, that is a complete evaporation of the prostate thulium fiber laser. So with this introduction, Salim, it's since long time we have to be on this platform. We ultimately brought you, and thank you very much. You will have around 30 to 40 minutes of time. Show your importance of the Diss and thulium fiber laser in the stone management. I really appreciate the amount of enthusiasm you take in this field. Thank you. Over to you.
Thanks. Thank you, sir.
Yes. I'm able to see your
Slides are seen?
yes, yes.
I'll magnify it.
Yeah. Bottom line right. Bottom right before the audio. Yes. That next.
It's clear now?
Yeah.
Audible now?
Yes, yes.
Good evening, everyone. The Pure YouTube channel watching urologist. And great thanks to Chandramohan sir again, giving me the opportunity to present my work on TFL and the DSS, which is unique, and the future RIRS procedure. To begin with, let us why the TFL DSS is important. To know that, we should have an idea on the conventional RIRS limitations. Definitely, everybody knows the conventional RIRS. It has a limited indication of the stone size, and it has a huge investment for a limited indication. For a beginner to have a RIRS program to start, it's very difficult. Feasibility of the recurrent investment. What I meant, like, the purchase of the scope loss and the laser fibers and all was the problems in the conventional RIRS method. Mobility of technology and the maintenance, the pre-TFL era. So oleum only available, which is like, from one OT to moving to the another OT. It's very difficult because we need a separate socket for the power connection. Learning curve is a very steep, even the 25 years down the line, being introduced in the conventional RIRS, still it's in the learning phase. I say, the cream of all the cream topic of all the conferences says that, it is still in a learning phase. The larger instrumentation and the working in a high pressure. These are the 2 points which is RIRS, conventional RIRS gives a lot of trouble because the complications are related to this. The larger instrumentation in the ureter, which is most of the time, more than 9 French ureteric access sheath, and working in a very high pressure system with the forward flow, which is the reason for the most of the complications, either the extravasation, hematoma, sepsis. How we can counter these two, the important problems we face in a conventional RIRS, will come to that. High procedure cost, definitely when the investment is high, the maintenance is high, and you can't move from one place to another place. The high procedure cost is the important thing for an individual patient. It will be overcharging, and it will be a cream procedure only in the affluent society. Pre-stenting and the procedure. Classically, the conventional RIS, the 3 procedures, to explain to the patient is quite difficult because stenting is required, and when you're taking a little bit of education, poor education people to explain that stenting is a one part of the procedure, it's very difficult. And another important issue with the conventional RIRS is the no stone handover at the end of the procedure, which is a very, very, difficult situation in RIRS to explain. It's a suspense whether stone is removed or not. When most of the time when you explain it comes in this, it's not acceptable by the most of these people. So now come to the new generation RIRS. What are the expectations from the RIRS? Does a combination of a suction, the new Z connector and the straightener, which I'm going to elaborate in RIRS, does this revolutionary step innovation towards, can we work towards creating a procedure which is ideal for the stone removal, the stone management? Will the new things what I'm talking today, or a DSS and the steps in the DSS, will make an RIRS a sheathless, that means no trauma to the ureter, fluoroless, less radiation to the surgeon and to the OT members. The wireless means less intervention, wireless procedure, which makes it less of a cumbersome during the procedure. Dust retrieval again, I mentioned it's important things. As sir mentioned, the dust retrieval is very important to proceed with the, it's very important to proceed with the,
Hello.
it's very important to proceed with the procedure. It's very important to proceed with the procedure to retrieve the dust and to give it to the patient also. Fragment retrieval. Sometimes end of the procedure, when the small stone you are doing, even the dust is retrieved, the small fragments in the multiple calyx. What happens sometimes, you fragment the stones, and at the end of the things, the fragments remains in the multiple calyxes. Whether can we do something like, reposition it in a favorable calyx and come out so that the fine dusting may not be required. Reproducible and daycare procedure. So is it possible to have an RIRS just like, a daycare procedure, a simple procedure where like patient goes at the end of the day? Is it possible? Stentless. I mean, like, not a zero stent, either no pre-stent, or most of the time whether we can avoid in some patients a post-stent. The no size limitation should be there for treating, and can stone be handed over to the patient? I think these questions are answered. Definitely, a RIRS procedure is going to be an ideal procedure for the future stone management, any size stone. Let us come to the RIRS direct in scope section, the components. I put it like a DSS network. There's a DSS network with a modified connector 1 unit. There's a scope straightener to make the ureteric access easy. When we say access sheath less ureteric access, it's not so easy to enter in unless we have an experience. But is there anything simple method where we can just like in a rigid scope we can enter into the bead? That is what the scope straightener is component is going to help. The scope modified working channel tip. If the working channel tip of the scope is half moon, that's a D exit. I'll show the video. The D exit definitely is going to be compatible for the section. And the multiple elements in working channel. I work with the basket and the laser fiber together in the working channel. Why? I'll explain, but it's a important component of a DSS. It makes it just efficient, continuous process and troubleshooting. DSS network and the Z connector. The Z connect, this is the Z connector. This is just a 3D printing. The final version is going to come up. The concept of Z connector comes from the, if you just see what is lacking in our RIRS program, flexible scope is the inflow. There is no outflow. Outflow is taken care with the access sheet. Anything can be done for that. That's what the thought process, because I work on a rigid scope, also exit with the suction. If you see the modified here, if you see the rigid scope, you can hold it opposite direction. If you can just one moment, yeah. If you hold the rigid scope in a opposite direction, like a flexible scope, you have an in and out. The same concept is a Z connector. If you have a connector which gives an in and out like a rigid scope, we can proceed with the procedure. It makes a miracle in RIRS. I'm coming to that connector. This is what is the DSS network. I'll show you the same Z connector. It can be simply be prepared at OT with the available of your three-way connector and our RIRS connector. If you connect into in an opposite direction, we can just see the lower part of the lower part is the three-way connector and the upper is our usual laser connector. You make it like to connect vertically in opposite directions. So make the lower is the inflow and the upper is the outflow. Why? Because this is very important. The irrigation goes from the lower and this is a network, suction comes out, because this network can be active or a passive. What I meant when the passive means if you're not applying action suction also, the part of this fluid can come out, so the internal pressure constantly can be kept low with this network. When you want to make it active, put a suction. This is how the suction tube goes to the suction machine. It's a small, like more suction machine kept the side of the laser machine. Again, coming back to the explanation of this connector and the connection, you can see there's a three-way connector here and the laser working, the connector is connected in opposite direction. The three-way connector inlet in this side to uh, the while standing on a OT table, your left hand side, the irrigation comes to most of the people, and the exit to the left hand side. This is how you connect again the irrigation. I usually use an arthroscopy irrigation set, which has a pump and it goes a nice, irrigation, gravity irrigation it gives. The exit to the upper this. As I explained, it is important to maintain this, the lower irrigation and the upper suction, because it's passive network. It partially, the fluid goes out when you need, and the active also when it's suctioning this thing, the most of the fluid, if you irrigation from the higher part to the lower part of suction, the fluid, most of the fluid gets into the suction bottle. This is the entire Z connector and the concept behind this is the concept behind the what product we are coming or the company is coming with. But this is a simple concept behind this get connector and our this network. Once this is connected, you just connect directly to the working channel of the Flexi. This active, this thing, you put a suction to this thing, suction which actively suction happens, and the passive, you don't put a suction, even you want to keep the while putting the working element, loading with the laser, and during the, you're putting the basket to the working channel, you can keep it passively open also. There's something new here in for a DS is the working channel loading. Why? Because I'll tell you, because here you need something when the suctioning happening, there's a dust getting clogged inside. We need something to push back. What I do here is the working channel is loaded with the sheathless basket. It is sheathless basket. Once you connect the in and out of the Z connector, when its irrigation is connected, suction tube is, the suction, this thing is connected. You pass in a working channel, sheathless basket directly. You need no need any assistant to manage your basket. You put a sheathless basket directly into the working channel and followed by laser fiber. Both remains comfortably inside. There's no problem with the suction. It really helps in the preventing your scope being damaged while suctioning. What happens? Your channel is not having anything to manage that. If the dust block gets into this thing, you have a problem with the irrigation again. Your pressure, extra pressure, you have to put to release that. Nothing happens. When there is something you feel like an extra amount of dust inside, just push it back. That's what is important. Now, taking out the exit is simple. Exit also laser fiber, you take it out, take out the basket, the wireless basket out. This is the exit part of the system, the end of the things. After that, you put the wire, guide wire, for the, because you're remaining the PCS. After once the procedure is over, take out the basket like that and pass the zebra guide wire and stent it. This is the in and out of the entire, the system loading in for the DSS. Well, now we'll show how what effectively is the suction happening with this is a my visual imaging videos. When at the end of the procedure, most of the time central I do visual imaging. So no dust, nothing. How the system is effectively getting contracted with the suction. This says like how effective is the suction inside the kidney. There's no trauma, no damage to the PCS during the suction. We are applying a very low pressure suction inside the PCS. We can see how effectively the system is getting collapsed. Intracalacial bridges are getting collapsed. We can see that nicely now. With suction being applied, you can see that the debris are getting into the working channel direction. And you can see the intercalacial bridges are collapsing, and just before it collapses, you just restart the irrigation. You don't allow it to completely collapse, so that it doesn't touch the irrigation section. You can ask the assistant to close the section. So again, it refills the system nicely. So you don't allow the entire system to touch your this thing. With the experience, anybody can do that. This is the method of suction. Either you can sniff it from the mucosa, or simultaneously during the procedure, you can do the end of the procedure, or simultaneously when you're doing the suction, that does get suctioning. The end of the procedure, in a small volume stone, there is something in the PCS, we can sniff it out and completely clear it. Or during the suction, during the lasing, continuously we can keep suctioning it. This is what I was talking about, the exit point of a working element, exit working element channel. That is the working element channel exit. If you see, this is one company right now producing the bioride. We have a T exit. Other scopes have this exit. This exit is suction friendly, DSS friendly. And dust suction, if you see the how you divide it, small volume conventionally indicated RIRS procedures, you can have a near 100% dust suction on table. You can see this with is a small volume stone. You can have complete dusting, and complete PCS can be resting on table and not necessary to have a stent in this patient. Large volume stones, we can nearly make it like, PCS dust-free end of the procedure so that you don't have a post-surgical event in RIRS most of the time. You can see how the dust volume is less. We can see the PCS mucosa clearly at the end of the suction. So both low volume and low volume conventionally, it is 100% clearance. High volume, we can produce the near zero. You can see near zero PCS is clear at the end of the procedure, and it get it to the bottle. We get various pattern. We'll be excited to give these tests back to the patients. If you see the DS is direct instrument suction. It's not only the getting the suction out of the PCM, dust out of the PCS. There are a lot of benefits with the DSS. That's I'm gonna explain in this video. See what happens as you enter in sheathless inside the ureter. Most of the time, you get these debris getting onto the tip of the scope. You can just suction it out. Enter into the PCS, we see a lot of debris. We can just suction it on to clear the PCS. So then proceed with the procedure. Even we started doing even for the pasta, so sometimes we can do that. It's a controversy, but it can be done. Another important thing is the repositioning of the fragments from one calyx to the other calyx. You can see from the inferior calyx, after fragmenting, I'm repositioning to superior calyx. You can just leave it like that, it gets drained without any problem. Or dust it again after reposition, because last one initially you're not able to reposition, then we have to fragment in situ, and then we have to reposition the fragment sometimes. This another important benefit is here, the calyceal movement. You can see as a suction happening, the calyx is getting moved up and closer. Here, the DSS allows you to suction and reach rather than flex and reach. This is another important benefit of DSS, what I felt. You can see the complete inferior calyx zone being suctioned, and visualizing is very useful to this thing rather than excess of radiation and excess of bending. Another important benefit is the residual assessment. We can see here after so many dust happens with the large volume stone, some fragment will does aspirate the suction the dust, and you can see a fragment there. We can proceed to the procedure and complete it. So this is another benefit of residual fragment assessment. Some people want a on-table 100% SFR or a follow-up case having some residual stone. What we can do, even from the superior calyx, these are the fragments which is like, the patient wanted a 100% SFR, so you don't dust it much there. Once it is very small fragment, it just closer to the tip of your, closer to the size of the tip of your laser fiber, you just suction it, bring it back half the suction. As you reach the half the meteorata, you release the suction. By the time your scope will be out and the fragments will be back into the bladder. You can see the entire superior calyx fragments have been brought back into the ureter. To the bladder. You can see at the end of the procedure, PCS is clear. No fragment in the PCS. And no stent in this patient. The multiple entries, you no need to put any stent in this patient. So the benefit I explained, clear the vision as we go to the sheathless in ureter, clear the debris in PCS and proceed. Fragment reposition to improve the SFR. Stone fragment retrieval to the bladder, residual fragment assessment, calyceal movement to reduce the flora and instrument straining, suction to reach the calyx, and keep the IRP low throughout the procedure, as everybody accepts with that, because intermittent suction definitely keeps the IRP low. You can see the vision clear end of the procedure. The vision is quite clear. That says like, the PCS is not harmed at all. So the conventional ureteric access is really required in our health. This was a facilitated multiple entries. As I showed, there is a multiple entries possible here with the straightener in place. Facilitate the irrigation nicely. If that is also happening, whether we need an US, maintaining the low pressure, and the limiting of bringing time. Again, all these are possible. Then again, whether we need a UAS with so much trauma possibility, and so much anxiety involvement, so much the problem with the learning curve, whether that is required. The DSS keeps IRP low. So does this change a lot more in RIS? Definitely yes. The access to ureter is going to change. It's going to redefine with something known as scope straightener, which is makes the future access to ureter sheathless, floorless, wireless. The access right now, we define inside the one, the 20 French sheath, access sheath by Guido Gasti, our access sheath. The simple way that it's possible to have a simple something which is to access, that is straightener. I'll explain what is straightener. Straightener is nothing but in male it's 24 to in male it's 24 to 28 centimeter access sheath like tube. In male, it's 8 to 10 centimeter. Principally here is male urethra size and the female urethra size. Male urethra size is 20 centimeters. So from VG to bladder neck, you keep a 2 to 4 centimeter extra. From outside to manipulate, you keep 2 to 4 centimeters. So it makes a 24 to 28 sheath size, 12 to 14. I use usually. And female, it is like, 8 to 10 centimeter sheath. Again, the same concept. Female urethra 4 centimeter. From VJ to the bladder neck, another 2 to 4 centimeter. Outside working part, another 2 to centimeter. This is a concept of designing the straightener. This is how we insert. You see how it makes the scope tip straight. If you see this, once the scope tip is straight, it is something like a rigid scope. You can see in you can see this video, the scope tip is straight, then it makes it as a rigid scope. We can enter anywhere inside the video. Every surgeon knows, the neurosurgeon knows to enter a rigid scope inside the ureter. You can see in male, the tip becomes rigid as you push it closer to this thing. This is a straight, making the tip straightener to access to ureter. How we introduce in female straight directly into the urethra and to the VUJ directly we can insert. Because here it remains, the straightener remains close to the VUJ, it won't enter the VUJ. In female, like a rigid scope, you just insert into the urethra. And push the sheath, and then the routine, like, VUJ, keep it straight at the VUJ and enter into the VUJ straight. In male, I introduced straightener over a ureteroscope. You can see the tube doesn't have any back this thing and a small length, so it fits nicely over the ureteroscope. Over the ureteroscope, you keep it and push it nicely inside. Most of the time you can go under vision or just thread it nicely, because without resistance it goes in, because all urethras admit up to 24 to 30 sheath easily in our TRP. So it's 12 to 14 sheath insertions, most of the time non-traumatic. You want to go under vision, you can go under vision. You can see the straightener is placed there. This is the endo view of straightener. It remains in the bladder. You can turn it to right or left anywhere. So you want to have a bilateral RIRS, it's very easy. You no need to reposition entire thing back onto the left side. You can see how nicely, you don't need to be an expert in bending and positioning, micro turning and all those, the classical explanation what we need to enter into the VJ. You directly direct like a rigid scope into the ureter. Similarly, turn out to the left side and go inside the left side nicely. So bilateral RIR is also going to be very simple with the use of a straightener. So does the most, because what does RIRS does now? We can coming to the expectation what we put. The most of the stone walls can be treated safely, single sitting or stage. Recurrent investments feasible. TFL technology mobility has happened because of TFL introduction. Least learning curve, smaller size instrument with no access sheath with minimal accessories. Modified procedure code. Most of the time, 99%, 95 to 95% no presenting is required. Visual imaging can make it as 100% SFR. So conventional to RIRS, to the new RIRS, the access sheet in conventional RIRS, radiation for access, pre-stenting for access, pressure pump and irrigation, complication due to access, ureteric access sheath and IRP usually be low, SFR low, high cost, size limitation is there. Whereas in RIRS DSS, the new concepts are straightener, floorless procedure, no pre-stenting required most of the time because you're not using access, keeping a stent for access won't be there. Most of the time you're able to do the primary procedure, gravity irrigation, visual imaging makes SFR 100%, low cost and no size limitation. So in my series, coming to my series, there are more than 1,000 cases I treated in RFL DSS in last 3 years. No case abandoned due to the intra section failure. Series has 28 stag wounds, only 3 PCNL in last 3 years. One for the patient was not compliant. He wanted to get it in one sitting, or when he came back for a second sit, he wanted to be removed. He don't want the stent for long. One was the encrusted stent. We are not able to pull it out. Another was a pre-stented patient, which is like, small stone. The stent when got, around the stone, and we are not able to pull it out. So that patient, we wanted a PCNL. This last 3 years, only 3 PCNLs. This is the amount of stone I treat, bigger stones. And this is the largest stone treated. It's not stag one, it looks like elephant one. And the good thing is they were able to give the stone at the end of the procedure. Yes, when taking the patient on a large stone for the procedure, RIRS, we need to have a staging counseling. Very important part is a staging counseling, because I consider when the staghorn stones are be treated as a 3 stones, always, because it's not a heroic job. It's a safe procedure what matters, not the thing. I mean, we are counseling for somebody, or somebody is requesting for a punctureless procedures. Definitely the counseling comes very important. Conventional 3 procedure, when it's acceptable, definitely an RIS, DSS, any stone size 3 procedure will be acceptable in future. Steps of the procedure, I put it forward. Any RIRS is mandatory to have an initial ureteroscopy for the junior to begin. Never, get away with it. It will help in assessing the PUJ, it will help in assessing the ureter, helps up to the PUJ, anything. Because after that, the procedure will be easy. No surprises on for this thing. Because anything you're visualizing the ureteroscopy, you can put a stent and come back. Anything we feel like, abnormal there. Access to the ureter, this is the video I'm just showing how the end of view, how the scopes are entered. Once it is a male patient with the staghorn patient, a staghorn case of 61 and 36 centimeter, I'm doing the procedure. Once the straightener is placed, your scope is directly goes into the bladder. And with little bit of stretching on the penis and the this straightener, we can make it as like straight one unit and enters the VUJ. And meanwhile, assistant will give a gentle pressure onto the pump so that VUJ is open. Because this is a primary case. This is after my ureteroscopy, VUJ after ureteroscopy. Just give a gentle pressure on the pump on the irrigation, this thing, which has a arthroscopic pump. Irrigation has a small pump valve. Just give this thing, we are able to enter into the VUJ within seconds. You can see it is a sheathless access to the ureter, straight. Like a gastroscopy, we can enter in. This is what I was talking. As you enter in the ureter, that sometimes the flakes over the the mirror there. We just suction it; it will be clear and proceed. Just suction it; it will be clear. There's no need to do extra manipulation. You can see the last stone. They just reaching the staghorn stone at the VUJ. Once you reach the VUJ, there's a basket comes in, and the laser fiber comes in. You load it, and work together. Start lasering. In staghorn stone, I'll come to the TFL setting. In this, when you manage the largest stones, it's very important that the setting should be variation. Variation in setting is very important. Not the one setting you do everything. No, method is coring, working inside, making it eggshell, breaking, and further breaking and fragmenting and dusting. The coring is always, I do 2 into 7.5 hertz. When you're inside the stone, you have a free space. You're not worried about the heat and whatever. You're not worried about the mucosa. Just work inside the stone. Reduce it to 1 into 6 size at the close to wall. Or when you have a fragment which is little, you feel it is stuck to this thing, it's a 0.1 into 60 is a beautiful setting, which makes it like, fragments fly out of the mucosa. You no need to work on the mucosa. It just come to the lumen. 1 into 15 is a beautiful setting when everything is fine. You're climbing the hill when it's a ups and bumps, you slow down. When there's a straight way, you just speed up with the 1 into 15 as a popcorning. And the undervision popcorn, if you want to, keep suctioning and undervision popcorning, you do at 0.1 into 60 hertz. At the end, last point, you suction it and popcorn it, suction it, it's better 1 to 60 because of very, very, very least minimal traumatic setting in TFL. The steps I explained, you can see here, steps is like coring, 2 into 7.5 setting. You can see it's a coring being done here with the 2 into 7.5. Once you get a hold onto the center of the stone, it's easy. You don't need to, this patient is under spinal. You can see once the coring is done, it's easy. Just place it inside, work inside the stone and make it as an eggshell. And break the stone after eggshelling. That is an important thing. Once it is become thinner, you start breaking the. You can see it become thinning is eggshell, the coring inside. Because I don't work from the surface, I work from inside the stone. And you can see you should be a good stone cutter managing the stagnant stone. You slowly learn the calicalization of the stone. Once the pelvic being done, you have to calicalize. I work from the superior calyx down to mid and inferior calyx because anything happening is better to clear the superior calyx so that no larger fragment comes and breaks. So the inferior calyx can be done later. This is how you break the stone. And it's called, I call it calyxalization, making the pelvic stone separate from the calyx. You need to be breaking the stone. You can see nicely now, you can see a crack being developed there. They put a multiple dots, then automatically it gets breaks. You can see the breaking of the stone there. And once that breaking is done, because already eggshell, till that fragment of the mucosa and further fragment and process. You can see you're not working anyway on the mucosa. You're just, again, it's a sharp stone, even we can't keep pushing it on the mucosa. And all the fragment of the mucosa, then again, speed up to 1 into 15 fragment, dust, popcorn, and come out. This is a case presentation I'm doing out in the 55-year-old male, large stone, 61 into 36 mm, 4 hours, 30 minutes, the total time took. The daycare procedure, 9 a.m. started, we finished at 1:30. At 9 p.m., patient wanted to go home, centrimal after 3 weeks, visual imaging, small fragment, vascular, 100% SFR in 3 weeks. This is the stone I'm just presenting, 61 into 61 into 36 mm stone it is. Yeah, faintly radio opaque. It's a you can see faintly radio opaque stone. This is the after I showed you the the endo. We have access to the ureter without access sheath, and once inside PCS you core it. You can see I'm just coring it. I'm not going to the surfaces visualize also. I'm not going for that classical dusting. This 2 into 7.5 core the stones in the center part. You can see the nice crater is developed, deepen that, and make that entire pelvic stone eggshell. Then it's easy to break, calyxalize it, and work on the one calyx, finish that, and then the time permits go for the other things. This patient was lucky, and anesthesia, he is a spinal, he tolerated the procedure well, he was not having any problem. So he proceeded with completing the procedure in 4.5 hours, complete clearance. I'll just speed up this for this thing. So you can just speed the calyx. Once you're it's a calyxalizing, breaking, and you can see I'm entering the superior calyx. Same eggshell and turn and keep most of the stone volume inside the lumen. Don't work on the wall. your all aim is to put the stone into the lumen and work at the center of the calyx. You can see here I'm entering the superior calyx calycial region. There's another fragment there inside. Again, the same principle. You can see the another stone there is also fragmented. You can see, you can start seeing the mucosa there. So pericardial mucosa, you can see. I'm just going to the completion of that, 4.5 hours time. See, it's after, I think it's the fifth hour. It's last half an hour of the video I'm just showing. The entire PCS, even though it's a 4.5 hours work, you can see the less of a touch. Other PCS, entire calyx we can see now. This we can do as Chandramohan sir is doing the end of the process. You can develop some whirlpool effect, and you can keep suctioning it. Or 0.1 into 60 is a beautiful thing which you can just, without mucosa damaging, you can raise the dust, keep suctioning, raise the dust, keep suctioning. This is the stenting part, just you can see how this is how the basket, you saw the basket coming out. When the suctioning, anything remain there, you can push back with the basket, and you can proceed. You can see the dust entire pieces, the maximum stone volume is corrected here. Fragmented and dusted here. You can see the because half of this, the volume of dust is very less here. This is the time, just I took a screenshot today, what is the time was mentioned, I'll see. It is 4 hours, 29 minutes, the last slide of the screen time. This is a visual image at the end of 3 weeks. It's the same way, it's easy access. Same way, enter into the PCS. This is after 3 weeks, you can see VH nicely, no problem. Ureter is clear. You can see even the 4.5 hours I worked inside the ureter. There's no problem to the ureter. Nicely, there is no edema even with the stent or a fragment going up. The pure, it looks like a primary ureter even after this. The PCS is totally clear. This is a video at 3 weeks. And there was a small fragment lying there, which was basketed and cleared, and no stent in this patient. This can happen in the PCNL. There can be a small fragment leaving behind. But here, with the visual imaging, because visual imaging is just like a stent removal, just see inside. Anyway, we are taking the patient for the stent removal into the OT. Just under sedation, stent removal, anyway, you're doing. This is the procedure under sedation. Just go inside, because the access to it becomes very simple with the straightener. You can just go inside the PCS and come out. This fragmented there only. The ureter, even because basket and laser fiber remains inside the ureter at working channel anytime. So you just fragment that and basket it out, and no stent is required. This most of the time I use, because of this technique and straightener, I use ureteroscopy inside ureter for the most of the stone, from the VGO to the this thing, if it's permitted. Better than rigid scope is the flexible scope for the ureter. This again 0.1 into 60 setting is a beautiful setting for the ureter. You can see the PCS at the end of the procedure. PCS clean, no problem. Ureter is safe. Stent removal, just a procedure, one procedure, and stent removal. That's all. which is conventionally a PCNL also, more morbid, 100% morbid than this procedure. No stent required. This is a test photography, how beautifully we can give the stone to patient because of this procedure. You can see is one of the neurosurgeons in future will be excited to see this pattern, because the same pictures we can give it to the patient. This is how we can be sent dried up and sent to the analysis. This photography in future will be loaded in the tutors, because you'll be excited to see the pattern which we get in the dust bottle. This is a dream. The boss was talking in last, our Oliver Taxis sir was talking in last one of the conferences internationally. The vacuum effect inside the this thing, the lab, how effectively the same can be reproduced inside the PCS. You can see the, as I mentioned, the last setting like 0.116 close to this thing. Continuously we can suction suction laser with the laser, laser you can keep suctioning and clear the stone. The same effect as what is seen in the lab vacuum effect, what is dreaming about. So coming to the specimen part, if you see, the open surgery used to be the specimen like this. Down the line in PCNL 1980, the specimen is going to be like this. Stone were given. In RA, this where the stone will be produced like this. But the only difference here is no scar. No trauma to ureter, no urinary trauma. It's a totally endoluminal, least invasive procedure possible. This is another slide by Oliver Taxis, sir. Always he presents this in this thing. Opens his presentation, open surgery to PCNL to RAS. Maybe the RARS, what is mentioned here, possibly in future RARS, Tfl Diss. Definitely is a game changer in urology with the TFL in place. Future possible to work towards a near complete endoluminal urology procedure. A safe, to conclude, I say it's a safe procedure is important for both neurosurgeon and patient, not the on-table SFR. It's important what we are achieving with this action is a safe procedure. Definitely on-table stone dust will come, and we have seen conventionally the stone will dust will go, but the safe procedure, which will be the prime importance with the suction in RARS. And RARS, the new generation RARS, is going to be the safe endoluminal procedure of the future. And with the TFL in place, the kidney puncture surgeries indications are going to be limited. And will it be the ultimate in stone management? Yes, I presented in April the same platform. I could not give it to the connection, everything, because of some restriction. Now the restriction is out. So the same thing is being mentioned, and future the professor is going to present the RS TFL suction. Exclusively, I put it like TFL laser is the difference making in suction, and because it produces such a fine dust, the ultimate step in stone management treatment. The Professor Oliver Tax is going to talk on the same in September in the International Conference Urology Association Asian Congress in 2023. This is how beautifully we can give this tone to the patient. You can see, the dust color, the dust pattern settling in. Thank you. I conclude with this.
Thank you, Salim, for your enthusiasm on this subject. Quick questions we will take. Some of them are asking questions are, do you keep your patients for RARS in T-tilt position?
Tilted position.
Yeah.
No, it's the routine position. I know, because when the flex is inside, only need to have any position with it.
Basket should be at the what level? Any damage to laser fiber basket or laser fiber to pass first and removal strategy? Which one you will pass first? Any chance of both getting fixed in channel?
No, that's why I put specifically that slide was put how to load the basket sheathless. The basket will come first. You place a sheathless basket first, and the laser fiber goes. Taking out laser fiber will come out, because basket pulling will be again the laser fiber damage. The exit will be the laser first and the basket outlet.
What is sheathless basket?
Sheathless basket is I introduced the sheath is out, only the sheathless basket is introduced inside. We are not keeping the sheath is taken out. The inner this thing, metallic this thing, and with the
Normally,
basket
sheath
only
and the
kept.
basket, can it be separated in Cook and Boston Scientific?
No, we are available with the BioRad to have that. It's a separatable, back separatable.
Is only in local companies it is separable, but in international companies it is not separable. You have to cut it off.
Cut
Okay.
it off.
Then Praveen Patel is the Shafiq member is asking jet connector where to order. Is it available for order or still is with you patency?
No, the patent in
Are
1
you
month will be
involved in the
available. It's
business?
going for a print.
Is it
Meanwhile,
available
it's going for a print.
no,
Meanwhile,
no.
we can prepare it.
Is it available in the market for sale?
No,
or
no. It's not available. Just I got a 3D printed last week. I used it and it is working well. And little modification this month it will be printed. 2 months time it will be
Are you
available.
also into the business or you are not into the business? I mean,
No, I just give an idea to the
you are
this
not
thing. I
into
mean,
the sales part.
yeah, not into sales. It's just into the one company preparing it for that. And
Praveen,
meanwhile, with the
size of
Z connector,
yeah.
Z connector is not necessarily to be printed. I mentioned there a three-way connector with the existing this thing can make
That
a Z
I understand.
connect.
That there is no problem. Praveen Patel has asked again, size of the basket suction is continuous or intermittent? You said it's intermittent, it can't be continuous.
Where?
Suction, is it continuous or intermittent? He is asking.
Yeah, it's intermittent when you require,
It
like,
cannot be
the
continuous
intermittent
because channel
suction.
is only one. So I think, anyway, I will ask certain doubts.
No. The suction is continuous as I showed in one video. It can be continuous as the irrigation happening and the lasing. You can do the suction continuously, not a problem.
But the channel in the flexible scope is only one. When the water is going, part of the water can be sucked directly through the entrance point.
That's why I initially mentioned the concept of irrigation going into the lower channel and the suction in the upper channel.
Yes,
The connector. This is very important. As I mentioned, the passive also. If you assess that and connect and see in a one bottle. See, once the irrigation goes in, the irrigation still keep coming. The suction bottle also filling, so that relatively there will be fluid inside. Same thing concept goes in when you want to do a suction. You ask your assistant on the other side just to keep the tube closed so that the suction happens effectively. You can release the thing, and it can happen both together.
Yes. So
because the volume of fluid is suctioned out, the dust also gets suctioned out with that flow of water.
In future,
we don't want any time to be dry in the system.
In future, if the thulium fiber laser is replaced by any very good laser, what will you change? You always write TFL. If the thulium fiber laser disappears after 10 years, what will you do? You know, neodymium YAG laser disappeared now. People were crazy. KTP is also almost disappearing. Green laser is also disappearing. Chromium also you are saying disappear. And if TFL disappear after 10 years, why to write TFL appeals? Why don't you write only
right now? Yes, right now, because see the future of TFL. Yeah. I got point. There's a lot of while putting the name also right now. Right now we live in this era. So I think for 10 years.
I mean to say APIS will not change, but TFL can change.
The TFL can change. RIRS and Diss can't change because that is the thing which is everybody are dreaming about. Access change is dreaming about.
Technique will not change, but technology may change.
May change. And if you better see the better this thing, like we wanted to dust something to be like in a very dusty and suction it out. If something can bring better, then that can be added on.
Yes. And what is going to be the future of the flexible scope size? Will it decrease? Will it remain same? Or will it increase?
Yes, maybe possibly a 1 French or half French. But see, the 7.5 French is a revolutionary. Because see, you need something to work in.
6 French will not come.
possibly it may come, but again, it will remain to like 4.5 inch rigid. Like, see, when you reduce it further and further, your working capacity and the accessory manipulation, everything it limits. What we
If six
wanted
French,
something like,
if 6 French comes with 3.6 channel, will you take it?
definitely it is worth again the primary things are going to the working channel 3.6. What is, if they're going to reduce on that, compromise on that and produce the scope, then it's going to be limitation again. If there is no working channel compromise, the size can be reduced. With the access, everything will be reduced. The primary RIRS is going to be better. More and more primary RIRS we're going to do. We are still 7.5 French. Why I'm telling, what
How
was
many,
the
how many,
rigid
how
scope
many of
remained
your
at 6.5.
how many of your cases ureter is so tight that you could not do primary RIRS? In 100 cases, how
In
many?
1 to 5%. In my practice, it remains to the same like in a rigid scope. If the rigid scope, like most of the time you put and stent and come like that only. This procedure, when there is a ureteroscope, the ureteroscope is tight for the this thing. That's what the primary ureteroscope will guide us. So most of the time, that is the incidence right now. It is coming down to 1 to 5%, wherein like a rigid scopy, wherein
Yeah.
you have some percentage of people, even for URS, you put a stent and come out.
What do you think? 6 by 7.5 rigid scope is bigger, or 7.5 by 9 flexible scope is bigger? Which one is bigger? Honestly, think and tell. Think and tell. 6 by 7.5 rigid scope is bigger, or 7.5 by 9.5 flexible scope is bigger?
Definitely, that is because the outside the tip and the proximal matters, because 6.5, 7.5, 6 is 6.5 is the proximal and 7.5 the distal and the proximal part.
Yes. By 7.5
yeah.
scope rigid is there with you, and 7.5 by 9 French flexi is with you. Smallest flexi biorad. Which one is bigger?
You mean 6.5, 7.5 versus the flexi?
Flexi, which is bigger?
The size is bigger is other one only, definitely.
Just it's my observation that in 9.5 by 11, the 6.5 flexible, the rigid wolf for rigid scope does not go even more than 1 centimeter. Does not go even more than 1 centimeter. 6 by 7.5 ureteroscope does not go 1 centimeter also in access sheath, smallest access sheath of hook. It will not go. Not even 1 centimeter. So all these sizes are fallacious. The beautiful part, what you are telling is flexible scope is much smaller than 6 by 7.5 rigid scope. That's why so many cases you are able to go into the ureter without damage. It is a good part. It's a good part. So this thing is wrong. 6 by 7.5 doesn't go, but whereas 4 by 6.5 goes in 9 French access sheath. That means a flexible scope of 7.5 is equal to 4 by 6.5. If 4 by 6.5 goes, on that day you can easily pass the flexible scope in your technique, particularly without access sheath, because you are passing ureteric damage. If you can pass, because you are skilled, it is not easy. And the third question I am asking is, how difficult manipulation of flexible scope without access sheath, whereas with a guard which is kept in the bladder? Do you find some movements in the inferior calyx difficult or not? Honest answer.
Definitely, the without anything there in the VUJ, it is not so easy, because there is be holding on the ureter at the, because here like a rigid, I am putting a straightener till the VUJ,
that
and with that
do you
support,
take advantage for use in the kidney inferior calyx a little bit? No. Will you hold it with hand or no?
where
Straightener will you hold with hand?
yeah, hold it a hand, make it as a
Or you
straight,
will hold
because
the flexible scope with hand? Which one you
no,
use?
the left hand will be penis, and the straightener is going to be little stable when you want to flex it.
Okay.
Because this grip will help us to flex it there, because otherwise it will be pulling down. The entire scope will be. So I'll put on the other hand little bit of holding on the penis, and this thing make a rigid system, so that the flexion will be easy on the inferior calyx there.
And you have set different laser settings. That is a very good part, and it is definitely important. And when will you use 0.1 and 200, 0.2 and 200? Will you ever use that setting?
That setting I never use it unless it's a smaller stone wherein like this thing. But in this setting, that popcorning concept I'm not using. My popcorning concept in the larger fragment is 1:15. Because it
But in
nicely moves out.
fragmentation mode, you will use in fragmentation mode.
Yes,
Popcorning in
1:15.
fragmentation mode.
1:15.
1:15 fragmentation mode. Majority of the people doesn't know that. They will keep in popcorn. In popcorn, 1:15 is not available.
Not
It is
available.
only fragmentation mode.
This is
Similar
the fragmentation. That's why I call the TFL is like inside kidney, the total scenario change. Inside the kidney, the fragment to dust. In
Yeah.
ureter, dust to fragment.
Yes. So,
Got my point.
do you have any settings with dusting mode in TFL? Do you have any setting dusting mode with TFL
Inside kidney.
inside kidney?
No,
Do
mine
you
is a
use
fragmented
dusting
setting.
mode?
Dust, I keep it like, at time when required, like, something like, 0.1 into 100 or 0.1 into 200 is my dust. Sometime when you require, I just experiment, but I never felt any advantage here.
Yes,
So,
I also feel
it's
the
like
same.
a blind.
So all the settings inside the kidney practically is fragmentation mode with variable 115 like that, so
Yes,
that everything will
yes.
happen. So popcorn mode is totally
Except for that 0.1 into 60, that is the last near the mucosa I want to suction and dust and suction it.
that is popcorn
Because
mode. That is
popcorn.
popcorn mode. It will not come in.
Popcorn means it's a dusting mode. I don't go for that popcorning and dusting mode. In
Is
the dusting mode.
is 0.160 dusting mode you are keeping.
Yes.
Yeah. So that means you don't use popcorn mode.
No popcorning setting as such.
Very important point for dear audience. Please remember TFL has multiple various setting. Dr. Salim is telling that he uses fragmentation mode of 1:15. Otherwise, to drill 2 and 15 is using, whereas not to
2
drill
into 7.5.
2 and 7.5. Okay, have you used holmium laser in your career?
Not much. Initially,
Can
2013, I
you
stopped my
do the drilling with holmium laser? You cannot do it because blast sheet will go. That blast sheet is not there in TFL. Your drilling is very, very useful in large stones to make it fragments like pneumatic lithotripter. That is a very, very, very important point you have shown. That is 2 watts and 7.5 hertz is wonderful setting.
Why? Because in the frequency of 7.5, the vision will be clear, and you have effectively that
100% correct.
Yeah.
This is exactly equal to pneumatic lithotripter.
Yes.
To extent, if you use 550 fiber in bladder stone, you can almost mimic 4 watts.
Pneumatic.
4 watts you can go up to maximum, and very less.
My setting for the bladder is 3 into 8.3.
Yeah, we use 4 into lowest frequency. 4 watts lowest frequency. The maximum wattage that TFL can go in bladder is 6 watts. That is very high energy.
Safely, because the lumen is more, the distance of reaching the laser fire is less.
And one more thing is the laser fiber burn back is seen only at that point. Just for the completion sake, what is your soft tissue setting for cutting the? I have not seen much of your work in enucleation of prostate. If you wanted to do enucleation of prostate, what is your laser setting?
Enucleation will be in 1.5 into 35, but most of the time, my technique of prostate is thulium vapor resection.
Yeah, that's why I know that. Vapor resection, what is the setting you are using?
50, the standard is the 50 hertz, and hemostasis noted, it is a 6 hertz.
No.
Very important.
Vapor resection, setting of TFL. Vapor resection.
Vaporization is 50, and the hemostasis is 6 watts.
Both settings you tell. Vaporization.
Yeah, that's a vaporization. It comes in a vaporization one setting. The vaporization is a one setting. Like you make it 10 or 50. There is no cutting and this vaporization. The one setting we make it 50 watts.
50 watts.
50 watts. 50.
And what about coagulation?
Hemostasis there, it is a 6 watts. Why? Because there is a least of when you cut and go, because we want a vision to reach there and we don't want any cavitation. It's a 6 watt hemostasis. I've shown in few of the videos. It produces a pinpoint hemostasis touch, which we want. As you cut the whatever the bleeding point, if you see sometime, you don't want to cavitate again and again. Either you vaporize a little bit, come out and just vaporize it, it stops. Otherwise, when the pinpoint you see, when you put an iron word, it cavitates again. So the 6 words will be just touching and controlling that vessels.
Have you ever tried in sinus? What is your setting in sinus? You might have not required because you do vaporization. You may not reach to the sinus. That is a different issue. But sinus usually doesn't get coagulated so well. If you have any experience, let me know.
No, they change over to ball electrode and
Ball electrode and that is a very good answer.
That is the life saving and come out rather than mingle there and more complication.
What do you think in suction? Because our topic today is this. What do you think the suction, normal suction, what we use in laparoscopy, if you connect to the flexible scopy, what will happen? Lowest level if you keep. In laparoscopy we suck, in PCNL we suck, in open surgery we suck. Same suction machine. Normally we keep in theater. Big.
This is the same suction machine. I'm not talking about this being a product of a biorad which is ready now. This is the entire thing is that fragment suction machine, which is the same like in a low pressure suction machine, what we use in other thing, the same suction machine.
So anybody can attach that. Only Y connector is required.
Yeah, that Z connector, what I call that. Also, you can make it in the OT.
OT. That's good. So on an average, in RIRS, for 1.5 centimeter stone, in this system, how much fluid you will use in the theater? And how much fluid you are getting out of roughly. For example, in RIRS, which I do, I use 700 ml of fluid and I will get in access sheath around 600 ml, 100 ml for God.
I'm not in access in that, but last I happened to see what's happening in the 3-4 hours stag-on stone. I used only the 4 bottles.
4 3-liter bottles or 500 ml bottles or what bottles?
400, I mean 3 liters of 4 bottles, because most of the things getting circled. I was like, not much. It's maybe like 1.5 centimeter, 1 bottle after time, most of the time.
1.5 you will get around 1 bottle. That it usually will get to 600 to 700 ml. You also calculate because you are using suction and irrigation. It will be useful for us to know what is the input and output. If it is exactly the same, it will be very useful because one drop.
Yeah, most of the time I just see, because most of the time what I assist with the thing is like no trauma. Most of the time the suction out fluid remains clear.
Only thing is fluid balance. You just check. Do you believe in
I'll try to analyze and let you.
Do you believe in LASIX in RIRS anytime LASIX?
Definitely, 100%. I asked this thing to give a LASIX because it keeps the irrigation this thing less inside. Hydration and LASIX usually I ask them to give.
Do you do RIRS only in spinal anesthesia?
Most of the large volume stones with the the cooperative patients, the large volume stone I prefer spinal anesthesia because you saw the movement. Once you're working inside the PCS, you're not necessary to flex your scope to move. The respiratory movement itself takes the length and breadth of the stone and helps in the clearing. That's why I analyze. The small volume stone, really you need an apnea? Yes, under GA.
This laser and basket usage is a sleek model of biorad or any other model of biorad? Have you tried these two in any other model? A flexible scope company? Any other flexible scope company?
Basket and flexi together.
Basket and laser.
Basket and laser fiber together.
Yeah.
No, the beginning before the 7.5, the 9 French, it was like this only opening tip. I not tried with that.
Other company, what happens? Have you used any other company other than
No. I'm using only biorad. But the thing is, the parabolic exit I showed here, the D exit that really helps in, and the parabolic way of the basket coming out. I use a sheathless basket, means I don't put the sheath and the tip remains there. That parabolic exit helps in the manipulation, helps in the pushing the dust.
Of which size? Biorad, which size?
The 1.9 French.
1.9 French. And
1.9, you take out the sheath, then it becomes less than half of the size.
like Dr. Kaushik Shah and Ashish Patel, you should also go into a company, I must tell you, because of your innovation. Not only in RIRS, because Indian companies are lacking. And if you can go into something laser invention also. Have you ever used 150 micron fiber? I use.
No. 150
You
micron,
may
I keep
really enjoy.
asking, but it's not
You may
available.
really enjoy because your suction capability will increase. You should buy only 150 micron
Yes.
from now.
Yes, definitely, maybe much better to have a,
Your suction capability will
here
increase.
the 200. See, that is something like an ideal instrumentation. In the last 3 years, there is no effort to say something. They want some procedure you're doing. There is something known as effort you put sometime. Here, whatever these instrument, I never the situation has not come wherein I put an extra effort. That means the things are ideal to work and proceed.
Yes. So with this, it's 1 hour session and a nice session, and you presented many things which will be helpful to the juniors. So thank you once again for sharing your experience. Excellent. All the best for the future.